we did other work earlier about systematic reviews, and then there was no trial of geriatric assessment and management. And so before we could plan a larger trial, we needed to do this feasibility trial to get some more information that we needed to plan a larger trial. We needed to know if it was feasible, what would be the best way of delivering the intervention, were all the adults interested in participating in such a trial, would our data collection points, because they're also receiving the chemotherapy treatment. So we needed to make sure we capture our necessary data to have any idea about the effectiveness, as well as the burden on the patient for being in the study. So for all these different reasons, we did this feasibility trial. Well, there's always been a focus, I think, in geriatric oncology on implementing geriatric assessment and finding the best way to identify those people that could benefit the most from geriatric assessment. In our trial, we just decided to go based on age, so everybody aged 70 years and over who was starting the first time chemotherapy treatment was eligible, because we didn't had a better way in our center for identifying who were the more frail patients, because that's the population we think that can benefit the most from geriatric assessment, but we didn't have a systematic way of identifying those, so we just went on base and age. But I think in more recent years, there's now more push for intervention, because an assessment is just an assessment. It's not going to change anything. And so we really need to come up with a care plan that's tailored to the patient, that addresses their priorities and takes into account their preferences, and then deliver that concurrently with their cancer treatment or prior if the issues are better addressed before, so that they go in the best condition for their treatment. Well, we need more intervention studies. Like we did our feasibility trial, Dr. Mohili's group completed a similar feasibility trial. So now we need a larger trials to really show that it is effective in improving clinical outcomes. In order for a lot of countries for this to be implemented, Canada included, we need cost effectiveness data that we can actually show the benefits for that as well. That geriatric assessment, of course, when you identify the issues up front and address them, and somewhere down the line it should save you money from not having unnecessary emergency room visits or hospitalization or something like that. So you hope that to have them better during the treatment, that you prevent more unplanned healthcare use. So we need those larger studies. Well, I think our feasibility trial, and we know from the observational studies too, like it's feasible to do these interventions. Patients are willing to participate in that, but in order to get into routine clinical care, we need to show really the benefits, because it's a cost-intensive intervention. A lot of cancer centers don't have access to like a dietitian, social worker, and all these other things that you need for care for older people. And so having this evidence could convince hospital administrators or other, those who are financially responsible, that to make these services more widely available for older adults.